Hi, I'm Dr. Joe Busch, founder of the Busch Center, which is a dedicated men's center for prostate cancer screening, diagnosis, and treatment. I'm an interventional and oncological radiologist who's been imaging cancer since 1998 as the first private PET center in the state of Tennessee. I've been in diagnostic radiology for over 40 years now. I've been involved in prostate imaging and prostate biopsy for the past 11 years. I've done probably over 20,000 scans now, and I'm approaching 2,000 inboard targeted biopsies. And the goal of the Busch Center is individualized personal care with compassion and from screening to diagnosis. And what I like to say is I am the visible radiologist. So not only will I be doing your study, but I'll be having heavy discussions with the patients before and after diagnosis and treatment. And currently in the United States, with the insurance industry, one size fits all. You have to do the PSA, the DRE, and the 12-needle random biopsy. And then for treatment purposes, they give us the option of prostatectomy and radiation therapy, the 5 different types of radiation therapy. Well, I would like to change that. So at the Busch Center, we believe in proactive MRI screening, since obviously you can have bad prostate cancer, and it can be seen prior to the PSA elevation, or you could have serious prostate cancer with a low PSA. So the MRI is critical for the diagnosis of prostate cancer. It's an accurate diagnosis. So we use advanced imaging with one of the latest generation of 3T magnets with 48 channels. And we do the inboard targeted biopsy, which is more precise and characterizes the disease better, since I was trained by people like Dr. Fuderer and Dr. Behrens. And we use the biparametric MRI. Since I've been doing MRI for over 10 years now, and have done and do over 1,000 a year, we have the ability to make a diagnosis using some of the newer techniques without IV contrast media, unless the case is mandatory for contrast media. We also do whole body diffusion, which I'm very proud of. We've worked hard on that. That is a difficult procedure to do well. And then, of course, the inboard targeted biopsy. We also feature the comprehensive patient education. After each one of our diagnostic scans, we meet with the patient individually from anywhere from 30 minutes to an hour, depending on the diagnosis. And we run over the findings on the scan so that they know when they leave there exactly what they have. And of course, after the biopsy, we actually interview the patients on their diagnosis, what we found on it. We're very proud of the fact that we can do the scan in the morning, the biopsy in the afternoon, and we have the results the next morning. So a lot of our patients, even though they fly in from different parts of the United States, we can still have discussions with them the next morning. When it comes to treatment, I've always been a proponent of focal treatment. If we can find it early, let's do focal treatment. If you think about cancer all over the body, that's pretty much the way we treat people today. I mean, we use focal treatment in the lungs, in the liver, in the kidneys, every organ, and particularly the breast, which when I was a big breast radiologist, we went for the lumpectomy. So I like to think of when Dr. Fuderer taught me how to do inboard targeting biopsies, and he showed me the first focal laser ablations, and eventually I was able to experience the TULSA-PRO technology with Dr. Fuderer. He also, I like to think of him, he's doing the male lumpectomy. So with TULSA-PRO, we're able to do this radiation-free, incision-free. We can customize the treatment to focal therapy or whole gland therapy. And I like the thought of one and done. In other words, we get the procedure done in anywhere from an hour and a half to, I think the longest case has taken just about under 4 hours for me. And so therefore the patients are up and out. The quality of life goes up. We don't have to worry about the rectal fistula with the rectal cooling device. We cool the urethra, so there's been no urethral damage. And we have the ability of treating the focal therapy without a TURP, which of course is a big deal with HIFU. And this is just a review. We believe that the MRI is the most accurate way, 95% negative predictive value if done properly, if interpreted properly. It is the most accurate way to do it. It's very cost efficient with no radiation, no contrast, and no harmful side effects. Now, establishing this TULSA practice, since I was fortunate enough to go to Europe a lot to learn how to do multiparametric MRI and learn how to do inboard targeting biopsy, I was very fortunate to watch Dr. Fuderer do the FLAs and the TULSAs. And therefore, after seeing that, I was able to, when TULSA was FDA approved, I said, oh boy, I can do it. And there was a lot of things that I saw in Europe and that I saw in the TAC trial that I wanted to try to change. And so after visiting a personal visit to Toronto in January, and then actually they came down and visited me, we had a lot of discussions about this. They agreed to install the TULSA-PRO in March. And so we did our first patients March the 25th, and of to date, we've done 23, and we have 6 cases that we have to perform over the next 6 weeks. And I can't thank my team enough, our TULSA team. To my right there, you see my wife, who's been doing cancer with me since 1998. And of course, to be honest with you, she's been with me on the last 12-year journey through prostate cancer. So she bluntly knows all the inside and outs. She also handles the nutrition and the catheter care. And then, of course, my technologist, he's been with me doing MRI of the prostate for 12 years. Jeannie, one of the ladies on my far right there, has been scheduling and talking with patients for 10 years. Carrie's our newest member of the team. She's been with us for a year working on this. Now, the next thing that makes our team work, and I can't say enough about these people, and one day I hope to put their picture up here, is that we use certified nurse anesthetists, which actually develop the secret cocktail for monitored anesthesia care and multimodal pain management. They are the ones that allow us to keep the patient still from anywhere from 2 to 4 hours without using general anesthesia or spinal anesthesia. So we're able to execute this the same way we do our inboard targeted biopsies. Again, and now their experience, they've done all these inboard biopsies with me as well as the 23 cases. And keep in mind, we have done we've done all these treatments as well as approximately 2 to 3 biopsies a week with the COVID virus here in America, although we only usually allow 1 patient at a time in the clinic. Case number 1, as you can see here, PSA 9.2, prostate volume 44. This is an interesting case on the top 2 slides. We sometimes, on these small lesions, when we're doing an inboard targeted biopsy, we absolutely do a DWI image with ADC mapping in B2000 just to confirm where we're going to put the needle, as well as the T2 image. We perform all of our inboard targeted biopsies using this Netherlands technique, what Dr. Fuderer taught me, using the fast TruFi imaging, which takes seconds. And also, if we need it, we do the DWI imaging at the same time. This is a 4+3 lesion. This next slide, you can see where I did the contoured customized treatment plan, where we're going to go after this single lesion, which has been biopsied. You can see it in the transaxial, the coronal, and sagittal plane. I can't emphasize enough, when you're doing the treatment plans, I think the 3 views are very important, depending on, I think you obviously need more than just the transaxial view. And I will tell you, the more I do, the more I rely now on the other views, as well as the transaxial view. And you see the thermal map also in the corner. Now, in this patient, you can see the treatment plan here, and you can see the live treatment on the, this is a maximum thermal map, and up above it in the yellow, you see the thermal dose map. One thing I love about the TULSA, to me, when you're doing the TULSA treatment, it's like a giant video game. You're watching the anatomy, you're watching your treatment plan, you're watching the current temperature, you're watching the maximum temperature, and you're watching the maximum dose, and you can check all your positions. As you can see on this patient, on the first pass, there's a couple of green dots up there at about the 9:30, 10 o'clock position, and I didn't like that, so we made a second pass, and as you can see, we cleaned those up on the second pass. Case 2 is a very interesting case, and a gentleman, and actually Dr. Fuder successfully treated his first cancer approximately 9 years ago, I guess it was, and then the poor guy came down with another cancer, and he was part of Dr. Fuder's original trial on FLA, but on this cancer, he did not want to go back to, I suggested he go back to Dr. Fuder, but he didn't do that. This was about 2 years ago, and instead, he went to Mexico. He spent a lot of money down there for holistic treatment, and it didn't work out. His PSA kept growing. They were monitoring with ultrasound, no MR. He came back to me, and unfortunately, his cancer was twice the size of when I first saw it. And I thought that the ADC map had changed enough that he needed a repeat biopsy, and sure enough, he had a higher grade tumor, 4+5, as well as a 4+3. And of course, with that high-risk diagnosis, I refused to treat him without further workup. So we did a whole body body scan, a whole body DWI on him, as well as a whole body PET-CT, PSMA, and they were all negative. So because of that, he elected to have TULSA procedure. He did not want a prostatectomy. He absolutely refused radiation therapy. He just said, treat the whole gland, Dr. Busch. So you can see his cancer is a big anterior lesion that's sitting up in the midgland in the base. And you can see it's bulging the capsule, which is concerning. But you'll see how we treated this. Basically, he got whole gland treating with carving out of both the left nerve and the right nerve, since there was no cancer in the vicinity, and also ability to carve out the ejaculatory ducts. I find it very interesting when I'm doing my TULSA procedures. If I can spare the ejaculatory ducts, I think that helps the patient. Sometimes I think you're going to have to take the ducts, depending on where the cancer is located. But on here, you can see the full treatment plan as well as the dose map, and you see the final subtraction images after the treatment. This guy's very interesting. He took it upon himself 4 weeks after the treatment. By the way, we had his catheter out in 6 days with no problems. In the 4th week, he pulled another PSA, which he wasn't supposed to do, but he called me all excited because his PSA was 4, and he was having, which is not low enough yet for me, but at the same time, it is some improvement. And more importantly to him, he was still having good sexual function in 4 weeks post-treatment. Case 3 is interesting because I did something that being the first radiologist to use TULSA in the United States, what I did is I wanted to experiment with doing a DWI imaging with the TULSA-PRO applicator in the gland. And we tried it, and lo and behold, we got very little artifact, as you can see on the B2000 and the ADC map. So this was very interesting on this patient. I believe that the DWI imaging is going to help us in the future in localizing smaller lesions, treatment of smaller lesions with the applicator in the patient. You can still see where you're going and what you're doing. This is interesting. This is another advantage of TULSA-PRO. You can see on this case, if you go back to the very first treatment, I did not like my treatment plan in retrospect after looking at it. So what I did, you can see at about the 6:30 and 7 o'clock position that after this first week, I changed the treatment plan and went back and picked up a little bit more margin on the bottom of this cancer just to make sure that I cleaned it up nicely, and yet preserving the nerves and the posterior part of the gland at the same time. Another clear advantage of TULSA, you can stop the procedure, change your treatment plan, and retreat. It's kind of nice. And here you can see the same patient with both the DWI images, the ADC map, the final treatment plan, and you can see the post-traction contrast study on the right-hand side there. Treatment time, we were able to get things done in about usually 2 hours. My longest case has been 4 hours. My shortest case has been just over an hour and I think 15 minutes or something like that. I look forward to doing these even faster and faster as we get more and more consistent and the team gets consistent. The team is very important. I don't like a lot of people in the room. They all have their roles. We get in and we get out. That's the name of the game. The way I look at it, the patient's still awake on the table. So every move counts. So our workflow optimization. So we changed some things from the original trial. Number one, we really put heavy emphasis on bowel preparation because I did not realize before starting all this how important it is not to have gas in the rectum and not to have feces in the rectum. And I'm talking about a small amount of gas. I'm talking about a small bubble can really mess up your treatment plan, particularly your thermal map. So this bowel preparation, I can't overemphasize, is very important. The next thing that's important, which I've already talked about, is my anesthesia team. That they are critical in watching end-tidal CO2, movement of the patient. We can't tolerate any movement of the patient, which we've been successful on 23 patients. So our CRNAs who are doing the monitored anesthesia care and the multimodal pain management. So in a sense, we're able to execute the anesthesia for a lot less expense than what you would say intubation. And then of course, applicator insertion was a big deal to me, even though I put 50 million guide wires in people's brains and their bodies as an interventional radiologist. I really thought we could get away from the guide wire, and we've been able to do that on all 23 patients. We use in-bore in-bore imaging. If we're not sure about where we inserted the applicator, then you just stop and you take a quick picture and you know exactly where you are, where you have to turn the coude tip and so forth. But really, you've got the image of the applicator anyway, so you might as well image it putting it in. And we've been able to put in the indirect device and the applicator in somewhere between 10 and 15 minutes on each patient. So that cuts down on a lot of time. And of course, I can't say enough about Profound Medical Team or TULSA-PRO team. They've always had a live person with me. Dipty's been outstanding. I think they learn a lot. I learn a lot. Rob's been on my shoulder on Zoom over every case. We discuss all the cases before we do TULSA-PRO. In other words, what are the dangers in what we're doing? In other words, can we execute this exam successfully? And that is a joint decision. We try to rule out all the hidden problems we're going to run into before we start. And I think that's been very helpful. Although I make the decision on my own, but I still value Profound's input because obviously they've seen more than anybody else in the world. And so our team, again, going back to the Busch Center, our patient experience is a personal experience. It's the visible radiologist. I spend a lot of time with my patients on education of diagnosis and therapy options. My wife, Kathy, also spends a lot of time. To us, you're treated like family. It's also do no harm. So we try to cover a lot of issues on the quality of life. And that carries through. We talk to our patients every day for a week after the treatment or until the catheter's out. And even after the catheter's out, we talk to our patients every week for the next month. So our TULSA patients really like the treatment. As one physician said that I treated early on, he said, golly, Dr. Busch, the treatment was nothing. It was putting up with my family. Or one guy that owns a car dealership was back on the job in 2 days. He gives me a video 2 days after he's on the job. He says, hey, look, Dr. Busch, I'm out here running my car dealership and I just got treated my cancer 3 days ago. So it's been the patients are what impressing me post-treatment. Obviously, there's a lot of preparation, but the patients, not one of the 23 patients has complained of pain or any, the catheter is the biggest issue. So we work very hard on pre-treatment catheter care, and we also work very hard after the catheter's in the patient. And obviously we place the catheter immediately as the applicator comes out, the catheter goes in using sterile techniques. So what can I say other than TULSA does provide flexibility, and I believe that it's going to be the treatment of choice for cancer therapy in the future. Yes, there's some things we have to work on. Yes, there are some corners we have to watch. Yes, we need long-term results. But if the long-term results come out like it takes to treat the patient, this is going to be clearly the best way to treat early prostate cancer. It could even be the best way to treat late prostate cancer in conjunction with other. For instance, we have a very interesting patient that we're going to wait on the results on that we just did this week that was on neoadjuvant ADT therapy and refused radiation and refused surgery. So he said, yeah. So when we rescanned him, it looks like there's no T3 disease. There's no, his whole body scan's negative. So we treated him. So that's going to be interesting. It really did shrink down his cancer, just as the radiation people expected it to do. So there's going to be a lot of flexibility with TULSA. You're going to have a broad range of treatments, including BPH. We've got 2 salvage patients on the books that we're looking forward to doing. And of course, we'll improve the workflow as we go. And it's interesting, the patients are choosing TULSA, okay? It's, I can't say enough good things about it so far. Thank you very much.